Hi, thanks everybody so much for having me here, for all of the work that you do, to Dr. Stefanik for putting this all together. So the intro really covered a lot. I'm Hans, I'm an intersex artist and educator. I've worked across a lot of different media, so sometimes it's comic arts, sometimes it's YouTube and video, but my work across the board deals with expanding our understanding of sex variation in a non-medical context, right? So the social, political, real lives of people who fall under the intersex umbrella. I'm proud of this work. The videos so far have been translated into, I think, 3 or 4 different languages. So it's something that is catching on very much in the community. And as Dr. Stefanik noted, my previous work was as communications director leading messaging and strategy around intersex policy in the United States. So Interact is probably the largest intersex advocacy organization in the US, possibly anywhere, with touching probably every piece of legislation and a lot of media as well that relates to stigma against variations in genitalia and other sex anatomy. So I noticed today that I think I might be the only person on the roster without letters after their name. And I think that's really important because clinical, medical, scientific perspectives are so important. And simultaneously, if that's all we have, we're missing a big part of the picture, right? We're missing a lot of other disciplines. So I always try to be expansive and focus on, a little bit of historical context, a little bit of political issues, because, no single discipline exists in a vacuum as we understand all of these different health domains and disparities. The point that I always like to focus on, regardless of how familiar someone might be with intersex issues, is the fact that human difference is so broad and so expansive. We see this in every physical trait. And so why would genitalia or sex traits, chromosomes, all of these things be any different? And so people often might wonder if intersex is a medical term, an identity term, political term, gender term. And as someone who's been immersed in this world from a community perspective for 10 years, my answer is yes. So intersex is a broad umbrella, and I try to help folks understand both a little bit about the history of these specific issues, as well as the concrete ways that intersex bodies might develop and some of the social issues, healthcare needs that people might have across their life cycle. And I stress that intersex, again, is a very, very broad umbrella term. There's a lot of different ways to be intersex. And what's controversial still is even how do we decide who meets that cutoff, right? So whose differences are significant enough to be labeled in this category? Because even among, say, non-intersex people, any woman, any person of any gender or anatomy, there's great variation across the board in general appearance, all sorts of traits. So the line is a little bit blurry, but what I consider intersex is often people who have differences that they're born with that are significant enough that they might cause stigma in a person's life, or they might cause attention for breaking some of those anatomical expectations. So intersex people have a difference that is naturally occurring in at least one component of sex. And there's a lot of things that go into sex, right? So we think of most people as following one of these 2 complete paths when their bodies are developing their sex traits. Usually you flow straight through and have all of these steps and have all of your traits in alignment on one of these 2 paths. That's the case for about 98% of people. And for intersex people, we have very creative interpretations, right? So there's a lot of different ways in development that a person can have variations that break these 2 paths. So that is largely what I'm talking about, people who break these paths in some way, and maybe that could be fairly minor, or maybe that's more significant. I think these examples are probably a little bit more significant. But I talk usually in terms of traits. And as you can see, sex is quite broad. It's an umbrella. There's a lot of different aspects that go into sex, which I love this Venn diagram from one of the Interact brochures that really breaks it down, because it's not only the things that you might think of the most classically in the inner circles, but it also goes as far as your expression of fat distribution, of facial hair, those sorts of secondary characteristics go into how someone's sex and gender is read. And so I also often don't talk in specific medical diagnosis terms. These terms are very useful for for understanding what an individual's anatomy is, for understanding what an individual's needs might be, what treatments a person might need. But I tend to talk more broadly in terms of characteristics of the different aspects of sex that a person could have. So intersex differences can be chromosomal. You might have chromosomes that don't align with your phenotypical or external genital appearance. You might have an extra chromosome. You might be missing that second X chromosome. There's different ways that you could be chromosomally intersex, although that's probably not the primary thing that a person would notice first, because most of us have no idea what our chromosomes are, right? Usually people might find out that they're intersex some other way, and the chromosomes are just an indicator of other things they might notice. You might have internal tissue that's different. So you might have ovaries or testes or a combination of that tissue, or be born with streak gonads. So you wouldn't have those hormone producing organs either way. Another part of it is hormone production and response, right? So what do we consider a typical level of, estrogen versus testosterone? What does your body produce? And how does your body respond to those hormones? So perhaps people have heard of androgen insensitive intersex people, which is where you have internal testes and an external vulva, and your body converts that testosterone right back into estrogen. So the response to those hormones and the balance of those hormones is another factor. Just a heads up that I do show, a genital drawing as well. So I think the most classical way that people imagine intersex, or what that is genital differences, formerly known as ambiguous genitalia, but having different variations that are visible at birth. And so I always try to make this point that, we all start off with the similar homologous tissue that can kind of go either way. So everyone has erectile tissue, whether that's the size that's small and a clitoris, or the size that's large and the urethra comes through and that's a penis. Those are the two poles of that we usually see. But of course, some intersex people might be in the middle. Likewise, with labia scrotum, having that opening to the internal sex organs, it's possible for a person to be a little bit in the middle that way as well. So I think that it's helpful to show this kind of illustration that breaks down the myth that intersex people are both. I find that usually not helpful in how we understand people's bodies. It's usually falling somewhere on a point of various spectrums. And so again, defining intersex is very fuzzy, because how do you define whose difference is significant enough to be considered under that umbrella? That's why I think that understanding it as a social and community type of context based on the experiences that you've had can be helpful. But this data from the 90s, I believe it was Anne Fausto Sterling, who looked at the medical terms for specific intersex variations and aggregated to find roughly how the prevalence of those variations points to 0.5 to 2% of the population, which is quite a large number by that even more narrow definition. So sex variation is huge. And even, there's people who might not have been considered intersex, but maybe had surgeries, don't have various parts. So there's quite a lot of variation as far as the different combinations of parts that a person may or may not have. So when we look at the healthcare needs of people with sex variations, whether those are more minor or hormonal, or whether those are genital variations, gonadal variations, I kind of conceptualize three categories that I'll go over some of the things that intersex populations might be needing specifically. The first, of course, being physical. Because when we talk about intersex issues, of course, we acknowledge that the main community issue is genital surgeries that happen to young children and infants. So as many as 1 in 1,000 children receive surgeries to normalize their genital appearance. And so categorically, being very clear about what I'm talking about here, these are non-life-saving surgeries that are usually connected to some sort of body anatomical gender alignment expectations and aren't immediately functionally necessary for an infant. So things like changing the erectile tissue, the clitoris size or position, vaginal depth, changing the urethra when it's not life-threatening, when a child can pass urine, and things like removing the internal testes when a person has a vulva. This was the work that we did at Interact, building on decades of advocacy by intersex people in the United States. This was a campaign that we designed with my peers, friends who were affected by this issue, by having had healthcare decisions made for them and feeling denied the opportunity to keep their body that they were born with, right? Because of these types of procedures. And I think that no matter how a person grows up to feel about that intervention, because most interventions still happen at under age 2, regardless of how a person grows up to feel, there is the psychological implication that something was so wrong or so shameful about your body that we had to change it before you could speak about it, right? Before you could understand what it was. And so these are the types of stories that we're often hearing, that we're sharing, that we work to amplify. And we point to sort of this double standard that we see in trans care and intersex care when it comes to surgical access, which is that, trans folks, are often old enough that they're able to voice their wishes and, fight for surgeries that they do want and opt into those decisions, while intersex folks, the surgeries in question are often similar or have similar high risks and are denied the opportunity to opt in to those procedures, right? To be able to have a chance to keep the body that they were born with. And so we look at this too in terms of, sexual and gender minorities. When we look at World Health Organization depathologizing being gay as a mental disorder in the 90s, depathologizing being transgender as, in and of itself a mental disorder or issue in 2019, quite recently, and not seeing that same depathologization of sex variations as physical disorders. We're still kind of waiting on that, hoping for statements that, these are natural variations and people deserve a chance to keep their own bodies, to have a say in their own healthcare decisions. So for intersex populations, the physical needs that you might encounter with patients, anytime there's surgeries, of course, there's scarring. So there may be issues with addressing the scarring from childhood genital surgeries, addressing accompanying lost or diminished sexual function that may come with that, and possible follow-up surgeries that were only made necessary because that first initial intervention was done. So some of the folks that were featured in the campaign were on maybe their over 10th surgery because of that initial surgery having been done that they weren't able to opt into as a child. And so we might also be looking at things like gender affirming surgeries to kind of change if, the surgeries that were done to a person ended up being not the direction that they wanted to go. We might be looking at that similar to trans populations, but with specific added layers. And we might be seeing needs for physical therapy, pelvic floor work, right? Again, addressing some of the issues that come with sexual function in surgeries, and care as intersex people age, because often, since so much attention is paid to infant and childhood interventions, there's very little resources for adults who are older, right? These interventions are done and then you either need hormones for your entire life or you may be dealing with these physical issues, but there's not a lot of expertise or resources out there for intersex adults, even in the context of, well, within my own experiences seeking care at, trans-related clinics, LGBT-related clinics usually still have no expertise around the needs of intersex adults. And so, of course, the second category is hormonal. So we're looking at possible needs like puberty blockers, maybe a need for some intersex youth with hormonal differences, right? Because if your body is making hormones that aren't in the direction that you want to go, similar to trans kids, you may need puberty blockers. You may need lifelong hormones if you had those organs and they were removed, or if you were born without them, as was the case for me. You're going to need things like DEXA scans to monitor your bone density, to look at how your body functions in the absence of having those hormone producing organs. And if anybody wants to go do some research on this, that would be fantastic. In my own experience, having gone to endocrinologists, gone to appointments, there really isn't much knowledge out there for people who were born without these organs or had them removed. Often I'm caught having folks reference, menopausal cis women with ovaries, which is possibly helpful, but definitely a different data point. And of course, you may need help to correct previous treatments or previous hormones that you were put on that maybe ended up not aligning with your gender identity or causing other side effects that you're not satisfied with. And of course, psychosocial, right? So you may need help, of course, connecting with peers, groups. I have some resources on that. Support for the full family. through a culturally appropriate lens, talk therapy, and of course, trauma-informed care always, deeper work on PTSD. I'll talk about that later too. But I think what a lot of people don't realize, and what I have come to learn through so many interactions with intersex children and adults, is that a lot of that attention on genitalia, sex traits, your body, can be interpreted, sort of psychologically as sexual abuse. So that sort of attention on genitalia that young children experience can cause a unique version of sort of that PTSD experience that really requires a specific trauma-informed lens. When I give this talk in Stanford Career Perspectives in Medicine class, I always root a little bit in the historical context of how we got here, how we got to the practice of surgeries being done on young intersex children. And so, of course, I only have under 20 minutes or so. I'm going to try to do my best on this, but how did we get to this point? We talk about the usual forces, right? So the usual systemic issues, the usual issues of oppression, and even the concept of two sex categories, right? That there's this idea that everybody follows this one path or this one other path completely that correlates with your gender in society and correlates also with your reproductive role. There's a lot of people who don't fit into that, right? And so we point out too that concept, the concept of opposite sex, was rooted in white supremacist and eugenic philosophies. There is a great academic text that breaks this down, The Biopolitics of Feeling. But the idea being that some of these eugenic thinkers posited that white people were considered more advanced because they had greater sexual differentiation, that there were men over here with these traits and women over here with these traits, and that others, didn't have as much differentiation. There was very much a racialized stigma around if your body was different or if you were hypersexual, if you were, intersex and Black and Indigenous, then that carried, additional stigma and stereotype with it. And we know too that in history, without anesthesia and without the prevalence of hospital births, often social integration happened and surgeries didn't, right? We had to figure out what to do with folks. So usually we would say, okay, we're going to raise you this way and see what happens. Connected also to sort of modern medicine, right? And how healing became less of something that was done by women and by healers in the sphere of the home, and more of something that became industrialized and standardized, as we see, for example, with hospital births. That's when, we are able to see every child, see the genitalia of every child, and then we compare to if this is, significant of a difference enough or not. And throughout history, when we look at, medicine in Europe, it was colonial doctors that were talking about aligning monstrous bodies for success in heterosexual marriage, because that was what a lot of society rested upon, was being able to function in either one of these reproductive roles. There's a great book that I recommend on that called Bodies in Doubt, An American History of Intersex, that talks about this evolution. And another academic that speaks really well on this is Catherine Clune-Taylor, who talks about how in the context of medicine, it's often been about assuming cisgender and straight as the defaults for how we want to shape intersex children. And I agree with a lot of that analysis. I think that the approach hasn't truly changed in a very long time. And I'll tell you kind of what I mean by that, rooted in the historical context, which is the intersex people didn't have the opportunity to gather and to engage in activism until much later compared to other sexual and gender minority populations, because the stigma was so great and the shame and isolation were so great. It was the internet that enabled that in the 90s. So when the first protests started happening in the 90s, the response was usually met with, well, we've decided that genital differences are traumatic psychosocially for the parents, for the family. Like, we have to keep changing intersex people in order to fit the social ideas. And that evolved a little bit, right? And we saw a focus on arguments around technique, right? Well, if we do the surgeries better, great. As opposed to focusing on, the ethics and the needs of adults. And now we're in the era of multidisciplinary teams, right? Where often there's multiple specialists that are, on a team of experts at a hospital that are, advising parents, advising families on a course of action, which may still include surgery, right? And of course, the critique there is, what about the individual? How do we know if the individual is willing to tolerate potential risks, sexual function, incontinence, those sorts of risks that are possible with these major genital surgeries that are not life-saving? And so we've kind of moved throughout history to looking for one specific marker that's going to measure and tell us which way we should put an intersex person, whether it's internal gonads, genitalia. I would say now that we're in the era of chromosomes, that if we can prove someone's chromosomes, if we test them in their XX, that makes doing procedures like a clitoral reduction acceptable, because we know that XX equals female equals they will want a small clitoris. And these are the types of arguments that we saw in legislation work in California from urology lobbies that were opposing intersex bodily autonomy bills. And we see this a lot too in issues like sports, sex testing, when it comes to having to find a marker for how we can argue what is enough of a woman. We need something to point to, right? So there's not really anything that's going to be perfect across the board that you can point to as a single marker. And so again, pointing out, some of the double standards between intersex and trans care of just wanting to come to a place where intersex people have the opportunity to drive their own healthcare, to have resources and have the opportunity to exist in their own bodies if they want to. Because being intersex can be dangerous, right? When your differences can be seen or measured or observed clinically on your body. That's why I see the dangers in things like looking for, trans brain differences or a gay gene, for example, right? Because intersex people know what happens when differences are visible, and you don't necessarily have as much choice in, coming out about those differences to the people around you and the, doctors, parents in your life. And we see pretty staggering numbers on this. So 2020 was the most recent largest study of intersex adults. This first figure is from Intersex Hospital Policy Guide about having changed providers 80% just because of language alone, before even any other reason. 40% of intersex people live with PTSD, which is often through a sexual abuse lens, and 32% have had a suicide attempt, which are quite high numbers compared to other populations. I wanted to make sure that I had a couple minutes at the end to focus on a couple of concrete tips that folks who might see intersex people in their practice could use to make sure that they're catching some of these specific issues for intersex populations. And the thing that I keep coming back to again and again is what outcomes will matter to this person is probably the number one question that I can think of, right? Not their family, not their parents, not the idea of what kind of sex they might want in the future. Myself and many friends all share the experience of, our childhood, teenage experiences were very shaped by medicine assuming that the changes that we would want to make to our bodies would be to have penetrative sex, when that may not necessarily have been the case. So what will matter to this person? And we talk about language, of course, too, right? So I think one of the most important practices is removing gender labels in favor of simply the name of the part. So to give an example, a lot of people talk about maybe female chromosomes, but it's really important to be explicit about what's meant. So XX chromosomes or XY chromosomes, et cetera, which works well for both intersex and trans people, and I would say for all people, because when we're specific about what we're talking about, then patients get more specific care. And that's why I also always recommend organ inventory. So I'll share the example that I recently had an endocrinologist appointment, which was really great because we had a conversation around what organs were you born with and what organs do you currently have and how does that affect your specific needs? Because if your forms just say female or male, then that's assuming sort of the alignment of those packages of traits, which may not be true for any person. Maybe somebody's had surgery, maybe somebody has a very specific situation. So I definitely recommend a more specific discussion around what parts a person does or doesn't have and what their desires for their body and their outcomes with those parts are. And it's okay to try. I love when people try and ask questions as opposed to assumptions, for example, that a person's always going to want to have penetrative sex, that a person is heterosexual, or that a certain outcome, having kids, not having kids, is important to an individual. We don't know. And I think the most important thing too is just that connection, that solidarity, connecting intersex people who have often been shamed and isolated into believing that they're the only ones, connecting with communities of people who are building, a culture and building shared social experiences around what life is like when you do have these sex variations. So Interact runs a group called iSpace. It's a peer support for under 30s. And there's another group that is a support group in the United States. They changed their name pretty recently to Interconnects. They were formerly AIS DSD support group. But that psychosocial support is so critical. And something that I always say too is like ask your hospitals, ask your curricula what their practice is, because right now only 2 hospitals in the United States so far through the work at Interact have made statements saying that they explicitly do not perform infant clitoral and vaginal surgeries. So we're always pushing, one by one to ask questions of institutions of why these practices are still happening. And this photo is an article that I wrote that I'm really proud of, profiles of 9 MDs who really shine in the space of intersex advocacy. So that one's on the Interact blog. I definitely recommend it. And a couple of other resources to plug. I might have a couple minutes left at the end. I don't know what our question situation is, but I'll plug the resources, which hopefully will answer some questions. Interact has a great suite of brochure materials. So this is one that young people wrote specifically for doctors that'll probably go a little bit more in depth on some of the points that I mentioned. Interact has, step-by-step an affirming hospital policy guide. So things like centering bodily autonomy, individual consent with surgeries, step-by-step policy guide written with Lambda Legal. And just last year, Interact's director, as well as an MD, co-authored a guide specifically for primary care, which has some really, really great tips. I recommend those, as well as with some of the stats that I mentioned earlier, the so far largest and potentially only psychosocial and mental health outcome study of intersex adults in the United States, which was conducted at UCSF. That one's on PLOS ONE. I can find the link if people are interested, or just Google. That should come up pretty readily.
1 minute.
Yeah, I think I'm on my last slide here, which is just if y'all want to reach out or follow some more of this work, my social handles are Hi Hello Hans. I have a YouTube channel that breaks down some of these intersex social, cultural media concepts, as well as the resources that Interact puts out are really good, as well as provider-specific resources.